My name is Erwin. On this occasion, I will present about grading assessment for breast cancer and its clinical application. Next. What is important of the issue? Some of the literature states that many things affect the prognosis factor in breast cancer. And it's very difficult to determine what prognostic factors most influence her. And we know three very important prognostic factors in breast cancer are lymph node stage, primary tumor size, and histology grade. The main issue to become the TNM staging system that we know. The problem is histology grades not yet include the staging. What is the reason? There are two things that support it. Because the minimum data set for breast cancer pathology reporting produced when the AJCC, American Joint Committee grade, is staging criteria. And the second, there are still differences in how to assess the histological grade. Next. Before we discuss about the grade, we must know about the grade first. Grade is histopathological maturity or differentiation, which is representative of aggressive potential of the tumor. So grade is described about how mature the tumor. In general, low-grade tumors have a better prognostic effect. Meanwhile, tumors that have a high grade have a worse prognostic. Then, how assess the tumor grade? Currently, the system that is often used in Nottingham grading system. This system is modification of Scarborough-Michelson, as we know. And how to assess the Nottingham grading system? Next. In the Nottingham grading system, or NGS, is based on the evaluation of three morphologic features. There are tubular formation, mitotic count, and nuclear pleomorphism. Tubular formation is the amount of gland formation, the cell differentiation, or how well the tumor cells are trying to create normal glands. And mitotic count is activity, how much the tumor cells are dividing or proliferating. And then nuclear pleomorphism is the nuclear feature. It's described about the degree of pleomorphism or how ugly the tumor cells look. Each has score of the 1 to 3. The higher the score means higher grading. So in the tubular formation, if that majority of tumor score is 1, score is 1. So this means that is low grade. Then the score 3, it means the high grade. Next. Next. After we assessing the three parameters, then the score are add up. A total score of 3 to 5 means the tumor is grade 1 or low grade or well differentiated. A total score of 6 to 7 means the tumor is grade 2 or intermediate grade. And a total score of 8 to 9 means the tumor is class 3 or high grade or poorly differentiated. And next. And then, what is the clinical application of the grading assessment? In the grading assessment for prognostic factor, after we assess the grading, what are the function and clinical application? The existing literature states that NGS, Nottingham Grading System, has a prognostic value equivalent to that of the lymph node status and greater than that of tumor size. Based on this, the high grade of a tumor, the progression will increase. So that the clinical application of therapy, we have to provide a more aggressive therapy. Whereas for a low grade tumor, the progression is lower, so that the therapy we give is not as aggressive as high grade tumor. Next. From this curve, regarding prognostic factor, historical grade affect breast cancer specific survival and disease-free survival. From the following Kaplan-Meier curve A, it is explained that grade 1 has a greater survival rate than grades 2 and 3. The higher grade of a tumor, the probability of survival is lower. Whereas on curve B, it was explained that the recurrence rate was also faster at higher grades. So that by knowing the grade of a tumor, we can assess the prognosis of a tumor. Slide. In the article that I present, it is found that there is a relationship between histological grade and clinopathological variable. In the article, it was stated that the lower histology grade was more common in elderly postmenopausal patients, have smaller primary tumor size, absence of lymph node metastasis, and AL positive. From this, it can be assessed an indirect relationship that TNM staging is also related to the histological grade of the tumor, but not an absolute relationship. And next, and then correlation grading and subtype of breast cancer. Literature states that low-grade tumors are usually luminal A-type, have an excellent prognosis, and generally have a poor response to traditional chemotherapy, but have an excellent response to endocrine therapy. In high-grade tumors are usually no hormonal receptor. Luminal B tumors tend to be poorly differentiated, less likely to respond to endocrine therapy, and more likely to respond to traditional chemotherapy. And the basal-like tumor is associated with poorly differentiated, which have the highest mortality and are most difficult to treat with adjuvant therapy. And high-grade and rapidly dividing tumors are more likely to respond to non-targeted chemotherapy and to attempt more accurate picture of percent dividing cell. Many pathologists use expression of Ki67 measure by immunohistochemistry. And next, and the conclusion, I gave suggestion that from the explanation of all this, first, the determining the grade is important for treatment and prognostic factor. And second, suggestion to include grading assessment in the TNM staging for breast cancer, like soft tissue tumor TNMG. And third, considering treatment with chemoradiation after breast surgery in high-grade tumor. It means in higher grade of the tumor, we must more aggressive in treatment. Okay, I think enough here. Thanks for listening. And your suggestion and comment are waited in order to improve the quality of life of our patient. Thank you.